Great. We'll go ahead and get started with our next panel. It is a pleasure to be here today for our panel on AI and healthcare. Just by way of quick introduction, I'm Rob Huckman, faculty member here at HBS, and I am thrilled to be joined by our four wonderful panelists here. And I'm going to let them each, in many ways, introduce themselves by responding to our first question. But our goal here is really to be interactive amongst the four of them and try in this process to learn a bit about the implications of AI for healthcare, not an under-Googled or under-ChatGPT topic for sure at this point, but certainly one that's generating a great deal of question as to what the implication of this incredibly powerful set of technologies is, not just for healthcare, but ultimately for human health. And that's actually where I would love to start. And I'm going to ask Francesca if she might get us started. But it's a question I have for all four of you, which is, if you think about what I would call the short term, and I will admit that I'm not the best at estimating what the short and long term is when it comes to AI, but let's call it 1 to 2 years. As you think about the most interesting applications of AI that could potentially impact not just healthcare, but human health, where do you see those applications lying? And so, Francesca, maybe we'll start with you.
Oh, wow. Immediately with me. OK. So a great question. I'm very interested in thinking about short term. 1 year is short term. I think my work and my research interest is really at the intersection of AI, generative AI, climate, and health. And we all know now that the number of extreme weather events are increasing, both in severity and in duration, both in the US and in developing countries. And so in terms of wildfires, extreme heat. And so my interest and one of the great potential of this foundational model and world model in AI is to analyze and learn from massive amount of data to inform local climate adaptation strategy, which means to prevent hospitalization and deaths from these extreme weather events. The opportunity is enormous. The technology is there. The data, to a certain extent, is there. And we know that there is so much talking about in climate with respect to mitigation and what we need to do 10 years from now, 20 years from now. The reality is that we know that probably tomorrow we're going to start having these massive heat waves or the next wildfires. And what can we do at the local level to prevent the largest number of deaths?
Yeah. You talk about having these tomorrow, and I'm beginning to actually believe you that you're literally telling us when these will happen. So we're going to come back to this question of environmental impact and its relationship to health. Nicolo, what about for you, as you look at this more from a drug discovery side, where do you see the major 1 to 2 year kind of application that most interests you?
Yeah, that's a great question. on the short versus long-term horizon, like 1 year feels short. It should be short. Like when we work in research, we hope that what we write or work on at any given point is publishable and interesting 6 months later. But if you look at the rate of improvement of the technology that we're all building on, if you think that what GPT-2 was 2019, GPT-3 was 2020, and then there was a gap of 3.5, and then ChatGPT came up 6 months later. What's happening, even just on a 6 months basis, is crazy. And so it feels like it should be like a short time, but it's really, really difficult, like very rapid development kind of moment. On drug discovery and the life sciences in particular, to answer the question of what's going to happen in 1 to 2 years, I think it's useful to go back to what I think is going to happen technologically with the models in 1 or 2 years. And I think you're already starting to see that happen, like longer context lets you ingest information and relate different kind of sources of information to each other within the context of the model instead of like pre-training or fine-tuning it. So you have this ability to ingest information just in time. And then you pair that with the fact that models are actually getting a lot more data efficient these days. So we have this notion of giant generative models that require an enormous amount of data, and that's true for pre-training. But after that, they're actually pretty data efficient, particularly in context. So you put these two things together, and my hope, and hopefully prediction that will happen, is a lot more advancement on rare diseases and rare cancers also, which are not rare collectively. If you take them all together, they actually make a good chunk of all cancer patients. But the possibility and potential of actually integrating information in context and reasoning about a particular cancer in context is extremely powerful. And I think that's where I think a lot of development is going to go over next year.
Yeah, and just as a quick follow-up, when you talk about the rare diseases being not so rare in aggregate, but each one obviously having its own challenges for drug development, do you see the major benefits for rare diseases coming in shortening the clinical trial period, or is it about identifying the targets or the molecules that actually we would go after?
So in the next 1 to 2 years, it's actually probably going to be on better matching between patients to clinical trials. In the longer term, I think target identification and drugability and drug development are going to be more important. But in the short term, I think just getting the right therapy to certain patients, maybe off-label uses and so on, is probably going to be more likely.
Great. Sham, you lead a major institute here that puts you squarely in the center of large language models and many other things in AI. What do you see as the application in the next 1 to 2 years you're most interested in?
Interesting question. I'm going to riff on what Nicolo said a bit about long context and capabilities. So I think yesterday at dinner, George Daly mentioned, I think it was even GPT 3.5, the capabilities on medical exams were the 85th percentile. So it's already has pretty solid capabilities, and it's improved since then. And the long context models have also improved. So right now, there's one which can hold about 1 million tokens. And for context, if we interpret this, 1 million tokens, say about 1,000 tokens per page. So this means it can utilize about 1,000 pages of history. And I think it's pretty fair to say it actually uses this reasonably well. And you start thinking about this, it lets you do a lot of things. And as another anecdote, when non-health related, one thing I was mentioning at dinner is like, I'd love to have this just look at my email history, like compose responses for me, which I can edit in my style, give me reminders. And the person sitting next to me at dinner, Ricardo, was like, this is what my startup does. And he showed me a little demo that he wakes up and he has composed messages for everything in his inbox. And I'm like, this is kind of what I want. And I'd really like this to be done in my style. And if I think about what this could mean in the medical domain, I'm going to go more, not maybe the rare case, say an average case. So either say something valuable to me as a patient or valuable to me as a doctor. I'd love it if it could just drop my health history into the context, I'm on One Medical, I love the communication, I have a bunch of emails back and forth. I'd love to have that dropped in. And this seems like a great tool for a doctor, and at a personal level, I'd also love it. Like, I read too much. Like, I read a lot of PubMed to see what's going on. I'd love it if they could do a web search, pull things into the context, and give me a summary. And this seems like really just a matter of figuring out how to do this robustly, but a lot of technology is here. So I feel like just like this email application, this could be a huge win for helping doctors to remember just all the conversations they've had with a person, because they see you for 15 minutes to half an hour. It's hard for them to swap everything in. Sometimes you see a different person. And even me as a patient, I'd love it if I can ask questions with my history. It can pick up lots of relevant PubMed articles, summarize it. So I think this is really just more broadly, if we have good language models, a lot is on the table.
Great. I don't know where Ricardo is, our email entrepreneur, but he's guaranteed to be busy during lunch for sure. But actually, Armen, that brings us to a question for you, because we talk about Ricardo's interaction with Sham, and we have an entrepreneur here who says, I've got a startup that does exactly that. And so as we think about the entrepreneurial opportunity that comes here, obviously that plays into some of your perspective into AI, but what do you see as the key application in the next 1 to 2 years?
Yeah, thanks, Robert. First of all, good morning. It's great to be here. It's a Harvard event, so thanks for inviting someone who attended a much smaller educational institute across the town. Doesn't happen too often. But so, at least for context, Flagship is a company that starts companies, it originates companies, and grows them all the way, in most cases, till IPO. So there is, to your question, Robert, there is a couple of things. One, I think there is the kind of efficiency improvement, there is efficacy improvement. But for Flagship, probably more importantly, what we think AI is going to do is going to help close the loop scientifically. So think of it as AI coming up with hypotheses, but then figuring out how to validate or invalidate those hypotheses. Now, there are obviously a lot of details. Where do you get data? Where do you get knowledge? How do you run experiments, so on? But we think it can be done. And then second, for us, we think there is a lot of new opportunities that in the next 1 to 2 years, AI is going to be enabling. One of them that we have spent a ton of effort in is going to be preemptive health and medicine. So how much we can go upstream of the disease, try to figure out the biomarkers, try to figure out what are the interventions and create them. And by the way, this is not just for physical health, it's also for mental health. So maybe those three to highlight.
Yeah, and you had talked about preemptive health, and I think you even distinguished it maybe from preventive healthcare. How do you think about preemptive even going further upstream than, say, our traditional approaches that we might have?
Yeah, I mean, interestingly, we did do it in our kind of physical security space. If we think about country protecting itself, there is kind of preemptive approach to it, right? You try to figure out where the threats come from and you try to address them. So similarly, why don't we do it in the kind of health space? So many of the things we are developing is trying to basically look, and by the way, it's like pre-diabetes is not what I'm talking about when I talk about pre-disease. This is like long before like someone will be diagnosed with pre-diabetes, for example. How do we go much upstream of that and figure out what are the few biomarkers? And I think AI is actually best for that in terms of trying to figure out associations that we can't necessarily figure out. And then at the same time, and figure out what are the interventions. Again, these are not drugs at that point because we don't know necessarily what they are going to do. If it's going to delay a pre-disease by 10, 15, 20 years, hard to call it a drug at that point. It's probably, we call it intervention, and figure out how to come up with those.
So can I ask a question? Is that public health?
We have a company that's actually doing it. It's called Etiome. That's been on this journey for about 2.5, 3 years now.
Yeah.
Was your question, is that publicly held or was that public health?
No, it's public health.
Yeah, is
So-
that public health? Yes.
It's what you're doing is that to me it sounds what I'm doing, which is
yeah,
public health, which is disease prevention.
That's a good question, though. Public health is more taking the same approach for everyone. Like vaccination is public health. This is basically saying for Armen, a specific approach is going to work, and we're going to try to figure out what that approach is. For Sham, it might be different. Francesca different. Nicolo different. Robert probably something completely different. But that's the difference. I think when you talk about public health, it's coming up with one approach for most of the population.
I will call it precision public health.
Precision. So there's an interesting prefix, not in all of these things, which is PRE, which is pre, and that both fills me with a sense of optimism, right? Prevention, getting out in front of something. It fills me a tad with a concern in that we are now predicting off of behaviors and other activities that I do as I go through my daily life with this or whatever else I have attached to me. And so it raises a question, I guess, as I don't want to get too quickly into the dark side of this optimistic opportunity, but we need to go there at some point. And so what do you see as the concerns you have that come along with perhaps the potential that you've identified? And we can open it up, so I'll go with anyone who might want to get us kicked off.
Okay, I'll start.
Go ahead, Sham, and then,
Sham,
and then
go
we'll
ahead.
come to Francesca.
Look, I think one of the big questions, at least in the language space, is reliability. So how do we get a way to think about reliability and tailor things to what people want? So and you know, part of this could be a mix of giving probabilities associated with predictions. Others could be reasoning. So a lot of the time, if it suggests something, if a human's in the loop, it could suggest something perhaps like with articles or ways to substantiate the argument for why. But reliability, I think, is going to be a pretty big one.
Yeah. Reliability. Francesca?
Yeah, so completely agree with Sham. I think that we need to also make a distinction in terms of optimism and caution, in terms that I'm super optimistic and really excited about all of the wonderful things AI is going to bring in terms of efficiency. And I think Sham gave a lot of examples, right? I think that's going to be phenomenal. And we all going to work with AI. I work with AI every single day. So the efficiency is important. On the other hand, I think when we need to be cautious when we are talking about making clinical recommendation or disease prevention recommendation for a patient, because then there is a totally different, and that's where we go back to the human in the loop. To me, one of the biggest liability I feel that we still have is to have enough rigorous data at the clinical level to train this model. So I spent my entire career analyzing literally the entire US healthcare system. I have Medicare claims data, Medicare and Medicaid for the last 25 years, terabytes of data. We've done everything on that. And these are messy data. And in the US, so that is the only representative data that we have on everybody. I give you an example. Years ago in 2015, I think it was 2015, when we had this massive snowstorm in Boston. And I got this crazy idea to ask all of the electronic medical record data from all of the Harvard-affiliated hospitals to understand it was a fun project. I wanted to understand the increase of cardiovascular disease right after the snowstorm, okay? And you will think, like, I'm an Harvard professor. I'm a professor of School of Public Health. We have 19 Harvard-affiliated hospitals, and I'm asking electronic medical record from the Harvard-affiliated hospital for the following 3 weeks after the snowstorm. It took 2 years to get that data. And they were a mess, right? So what I'm trying to say is the data are there, but when we're trying to train this massive amount of model, even to address a simple question, I don't think that we are there because of all of the issue about patient confidentiality, and because these data, I'm telling you, are a mess. So I think I think there's going to be a tremendous amount of efficiency, a lot of exciting things, but unless we overcome the ability to have AI and ML data ready, that for patient, individual level patient, it's going to be a huge obstacle. Our ability to really trust of what these models are telling us, again, for individual recommendation, it's going to be really challenged.
So the concerns seem to lie with data quality and availability, perhaps even more so than privacy on this?
Yeah, exactly. I'm actually, I don't understand. I think maybe this could be an amazing breakthrough. There is no problem about data privacy because all of these models are trained on this massive amount of data on, behind door, on the back end, right? And then when you have trained the model, then you do the fine tuning. But someone has to be able to say, I'm going to make this data available to whatever the team that is going to train this model. But this AI model is not going to give you the individual level information. After they're trained, you're just going to learn about these gazillion of parameters, and then you can do fine-tuning prediction.
Yeah, Armen, go ahead.
I was just going to add, I think it's not just the EHR data in terms of kind of data quality and consistency that's a lot of time an issue. Like we and our company spend a ton of effort, resources in going and actually generating biological data because you need consistently generated high quality data. It's one thing we can talk about, and Nicolo mentioned like in 5 years, the progress that's been made from like GPT-2 to 4 and then soon probably other models that are going to come along. But if you look at the data that it was trained on, it's basically everything that we put and publish and so on and so forth. When it comes to biological data, high quality biological data, the availability is very much of an issue. So like many players, including obviously a lot of flagship companies, would be spending significant resources in going and generating.
Yeah, no, I completely agree. That point resonates very well because in some sense, the GPT family models have been trained on data that is just captured. It just floats. We are generating it right now as we speak. You know, you transcribe, you can train a model. Biological data needs to be carefully measured. It's something you had an intention to measure. Yeah. And once you measure it, very often the cell that you are measuring things on doesn't exist anymore. You destroyed it. Mm-hmm. And so it's particularly important to record why you are measuring something, what the measurement is, and that's on the life sciences side super important. Yeah. On the healthcare side, where the data is kind of like, you capture it as part of like patient-doctor encounters and treatment, one thing that I think it's important to remember is, yes, human in the loop, but also these systems are socio-technical systems. So, and the two things are so intertwined that goes beyond just, hey, does a human review this, but also like what's the interface between the model and the human and the model? And those two interfaces are not the same. And we think a lot about chatbots because that happened to be the thing that worked super well for GPT to popularize it. The technology for ChatGPT without the chat interface was, what, for 6 months? It was available for 6 months before. So like these, thinking comprehensively about the system as a socio-technical system and how the patient has GPT, the doctor has GPT, bringing all of these up and thinking cohesively as a whole system is probably going to be important.
Do we need a different, I often think, if we could just have a collection of data about our individual lives straight through that sees no wall between the clinical engagement and my daily exercise and my work and my respiration, whatever it may be. Obviously, privacy-wise, it scares me a tad, but at the same time, it seems like it brings this degree of integration you're talking about.
That's a Sham GPT idea.
Yeah, this maybe is a Sham question.
But there is a sense in which once you get to models which can utilize long context, you can avoid a lot of the privacy issues because if you can already use 1,000 pages, you don't need to share your own history dumping it in the model. And if the model could summarize things about you, then this can be entirely personalized where it never even needs to use your data for training. It could literally just see your entire context, bring in information, and utilize this as context. Yeah. So a fair bit can be mitigated this way.
Yeah. I mean, it raises this, I guess, this next question too, and I don't want to focus just on one country's policy, but if we just talk generally as how we think about what would be needed from a regulatory policy standpoint to create this information in a way that would perhaps be palatable to the bulk of society. What might we need to change on a policy side?
So what do you mean by this information, so to speak?
Well, if we just think about creating kind of information that has the power to sort of carry through both the biological, the clinical, other forms of our activity, and seamlessly able to kind of connect this, are we thinking about a different regulatory environment to generate data of that type? And if so, what changes might we need to see? Mm-hmm. You can use the US as a benchmark maybe, but you could use another economy as well.
So, I mean, maybe I can just, I'm sure that everyone has a lot of opinion on this. I think that just to start, and again, this is a really brainstorming about a skeleton of what would be the critical ingredient for, I would say, regulating AI for preventing disease in the US population at the individual level, right? Let's frame that. I would say clearly privacy. And I think that is something, as Sham and my other colleagues have pointed out, is absolutely attainable. Two, there are a lot of technological advancement that we have to do to deal with integration of different type of data, multimodal data, from images to biological. I think that the policy there is, and that's hard because I think it's imperative that the quality of the data has to overcome a certain threshold. The quality of the data, and I think mostly the representativeness of the data. And that is also another thing that we haven't talked about, but often when we are dealing about integrating data from different populations, often, especially in the healthcare setting, we forget that some population will be vastly underrepresented. And so I think patient confidentiality, maintaining the individual level privacy data, I think the quality of the data that we use to train this model, and 3, the representation, so then we don't make individual level recommendation on a patient from a model that is trained on a population that doesn't include that patient or it's not representative. I mean, I will start with that, but I'm sure
I actually
my
think
colleagues
the
have
underrepresentation question is a fascinating one and actually relates in some ways. I mean, I think Sham was kind of talking about what we can bring forward about someone without them themselves having to bring it forward. But when you're in an underrepresentation situation, it seems like a very fundamental challenge of trying to create inference off of that. But how are there ways we can begin to broach that challenge?
I was going to get to maybe somewhat of a different question, Robert, if you allow me. So I agree with Francesca. There is also the whole point of kind of maybe federal mandates or requirements or kind of business model alignment, and I'll elaborate what I mean. Let's talk about preemption or prevention, just like we started with. For a regular person who has health insurance, their health insurance company doesn't necessarily benefit from preempting a disease. Yeah. You'd say, why? Because that person in 3 years is going to switch to a different provider on average. So to spend the time and the money and the resources to actually try to preempt or prevent something doesn't necessarily make business case. So then they're not necessarily going to invest the resources to do it. So how do we, along with all of the kind of data privacy rules, regulations that we need to put in place, how do we also think about the business models and the kind of federal mandates that have to be in place to get something like that actually working? Yeah. Not just in terms of data sharing, but also in terms of making the whole system work.
Yeah, I think the business models are a fascinating piece that I want us to come back to, and I just want us to pick up though on this representativeness question, and then we'll come to the business model because I have a follow-up for you on that too. But are there ways to address this representativeness challenge that Francesca's raised here, because it's a key piece of equity and other things that we need to think about?
Well, I mean, there are, as long as we're making sure that we have enough data for the population of interest. I mean, let me give you just a simple example. We see in the United States that there has been an increase in colorectal cancer among younger population. Mm-hmm. And we know that there are vastly different that in the black population in the U.S., the colorectal cancer incidence it's higher in the younger population than in the white, and now there are a lot of papers in the literature that are actually start talking about the fact that colorectal cancer in the black population in America is actually a different disease than in the white population. There is plenty of evidence that and I'm not a doctor, I'm not a colorectal cancer doctor, but there is an overwhelming amount of evidence that the clinical treatment that work for the white population do not work for the black population. So, a simple solution is that when you're training a AI model to provide clinical recommendation in that context for the black population, it will need to be trained on massive amount of data for that population. Or, if you borrow information on a white population, making sure that you're borrowing on whatever samples so they are transferable, right? So I think that's something we really have to keep in mind. Because right now, I don't think we're paying a lot of attention to that.
Yeah, I mean, to some extent, it's hard for me to see regulation really addressing these things. I think ultimately, it is just education and people caring that we can put in regulation, but the ways the laws are, and in a free society, I think it's pretty hard to do some of these things. But I think as there's more social awareness, I think ultimately with social awareness, there's a forcing functions that we need people and companies to want to do the right thing and collect a lot of the data. And I do think places like Harvard and the next generation of people are becoming aware of the broader social issues. And I think when they come into these roles, I think you do want to have policies that can look into these things. Because regulation, I think, tends to be after the fact. It's hard to measure these things. But I think in a lot of ways, if we have awareness, I think the technology could also help us in understanding groups who are missing and ways to quantify this. So in some ways, I think if we're aware of this, I think it's pretty important to start thinking about ways to quantify which groups are we missing, what's the impact of it, and how do we address this.
Yeah, unless you think we're here at Harvard Business School and I'm, as a faculty member here, jumping too quickly to regulation, I want to come back to Armen's point about business models and our need for them. You pointed to the fact that we see churn in insurance, perhaps yearly for many enrollees. And so how are the insurers going to have the incentive to make the investment in some of these things that will have long-term effects on health? Similarly, for providers who, as much as we talk about the fact that we're starting to pay them on a risk-based basis or on capitation or on some sort of flat amount to care for the needs of a patient for primary care, we're still paying most of them on a fee-for-service basis as they come into a physician or other office. If AI does its job well, hopefully it would keep us from having to go see those physicians in their offices so frequently, which on the one hand, we would love. I think physicians would love the idea that their patients are healthier. On the other hand, if we can't figure out how to compensate them for their time that they still need to spend working with their patients, we have a problem, again, from a business model standpoint. How do we deal with the business model challenges that AI might raise here?
I'm not sure I have the comprehensive answer, but I think some of the pieces of it is also going to be making providers more efficient in what they do. I think we're at the dinner yesterday, it's like, I think someone highlighted that you go to a doctor and they spend half of the time not necessarily observing you, but writing notes. Well, again, why would they need to spend so much time writing notes? Can you actually take that time away from them and have them actually focus on what they're going to be focusing on? That's one way of doing it. I think another way is, as you said, it's like how preemptive we can be in terms of actually admitting the potential patient to a hospital and actually figuring out what the treatment plan can be long ahead of before we are actually even kind of walking into the office. That's probably the other piece.
Yeah. Nicolo, I want to come to you back to drug discovery.
Yeah.
Because that's obviously a huge opportunity you've identified. What do you see as the challenges that we need to keep our eye on with respect to bringing this technology so squarely into drug discovery?
Well, let me answer first.
You can go for it. Yeah.
That question, I really like that question. I also like this one, but
you answer any question you want.
Reflecting. It's
Totally different one.
It's just by my own rules here. No, but I really like the question because I was reflecting in the life sciences. The business model question is very different, right? Because there you're, and there is the life sciences side and the technology side. So on the technology side, like we are trying, all the tech companies are trying to lower the cost per inference. Just because you need to serve, like as Ethan Mollick was showing, like you need to serve that thing in PowerPoint, in Word, in ChatGPT. In the life sciences, you're okay with a 4 pass-through model that costs $1 million if at the end you have a lower risk of failure for phase 2 clinical trials, for instance. So the business models there are very different because you can actually completely change the structure of what you do. Instead of being just a platform that offers, do inference on us, you can actually provide higher value services such as let's design something. Okay, now back to the original question about risk in the life sciences. I'm not super, and maybe I'm wrong in that, but I'm not super concerned about underrepresentation risk when it comes down to the early phases of design of a drug. I think it gets into, once you start developing patient-derived models like organoids and things like that, and cell lines becomes a lot more relevant. So I think the biggest risk in the life sciences are actually going to be on the biosafety front. And there are kind of two main branches of that. One is on the increased access to the capability to design bad things by actors that wouldn't have had access to those things before. And on the other, and that's somewhat concerning, but the regulators are pretty good at that. The agencies are pretty good at that. There is a separate branch, which is about how do we know that these generative models are not designing things that are really bad, but we cannot verify that they're bad. And so we go and hook up these generative models to lab equipment to design proteins. Like, how do we make sure that the protein they sent to design is actually safe to be made? And that's, I think, right now my biggest concern by far on the uses of this technology.
Yeah, and obviously a substantial and meaningful one with significant implications, for sure. So I want to come back to our first question, which was, if you recall, which was, what's the application of AI that you think in the next 1 to 2 years is going to have the biggest impact on human health? And if we were sitting here 5 years from now, and since I'm not very creative, I'm going to open the panel the exact same way. But if we're answering this question 5 years from now, how would your response differ as to what you might see 5 years out as the most significant application of AI at that point? How would it change, you think?
You go first.
Armen's.
Yeah, you all just decide amongst yourself who goes first. But I think Armen,
I want to hear
let's.
what Armen says.
What do you think? What's different about your?
As humans, we are pretty bad at projecting forward, so
It's costless.
I will, exactly. But I'll try. I think what's going to surprise us, and I'm not sure if I'm going to get to a specific application, Robert, but I'll just maybe try to channel my inner creativity. What's going to surprise us, I think, is the capabilities that are going to be enabled by merging different models that I think we are just starting to explore, and I think very few probably have done. Again, this would mean we have multiple large language models. We are trying to merge them and figure out actually how it's going to work. One may be very well trained in math. Another one might be more kind of biology focused. Another one might be more kind of GPT-4, like more generic model. That's one. And then the other is going to be related to that, but also very different, is going to be multi-agent paradigm. How do you actually have multiple agents, again, not just 1, 2, 3, but 10, 100,000, 10,000, 100,000 agents that are going to work together to accomplish different tasks, given a direction or an application in mind that you are going to be actually kind of almost trying to put guardrails together to guide these models to do. So at least that's what I'm excited about. Maybe in 5 years when we are here, I'll say I was completely wrong, but who knows?
So I'm going to have to move my lexicon from agentic, which is my favorite new word, to now multi-agent. I'll prepare for that.
I'm not sure if it's agentic or agentistic.
Yeah, there we go. Okay. Other thoughts on this, if we're having this conversation 5 years from now? What's going to be our short-term answer then? Sham?
I'm probably closer to, I like to give odds, so I feel like we can forecast things, but how confident are we? But so your question is more, in 5 years from now, what do we think will be the next short term?
Yeah.
I mean, I think I'm pretty excited about the impact of, drug design and, both personalized medicine and ways it can actually hit, I think, less developed nations too, because once, part of the aspect is that, I definitely understand the tricky part of having a business model, but I do feel one of the things that as companies get more profitable in this space, I do think it can lower costs, and as the costs get lowered, I really would like to see in 5 years from now ways to impact, the poorer nations, and if the technologies actually get cheap enough, I think it could be even profitable for poorer nations to utilize these technologies. So I think this is, for me, one of the, I'd love to see it happen. I'm always maybe more of an optimist, but I do feel technology can really benefit poverty.
No. Nicolo, what?
I can say whatever I want, because in 5 years from now, my agent is going to be on an iPhone.
I was going to ask how many of us were actually going to be on stage.
I'm going to send over the agent, take responsibility for whatever I say next. I think in 5 years, there is actually a pretty good chance that we are, the next short-term turn of the crank will actually be about the truly personalized treatment in such a way where it become actually commercially viable and feasible to actually design more specialized therapies that truly are designed for the individual. Like right now, there is a lot of like diagnostics even on the market that they're not used in clinical practice because they can diagnose something, but you cannot do anything about it. And I think my hope and prediction for the next 5 years is that we're going to start to see more diagnostics that give you some signal that you can actually do something about it.
Yeah. We often refer to companion diagnostics.
Exactly.
And it's always a challenge when the companion diagnostic precedes the therapy that goes with it. So, yeah,
Yes.
so absolutely. Francesca, your thoughts on 5
Yeah,
years?
so I completely agree. I think that for me, it's a little bit of a mix of what I hope we'll see to happen. I don't know if I can predict it will happen. I mean, clearly, the potential for personalized treatment and personalized prevention, because I'm always love to think about prevention. Let's prevent the disease instead of before worrying how to treat it. I think it's an enormous opportunity, and I think it's going to improve. I think that 2 notes of caution. One is I really hope that this personalized prevention will also be targeted and delivered for the more marginalized population, both in the US, but also we haven't had a chance to talk about, but the enormous opportunity for global health and in low and medium income country. I think that, again, it all depends on the data. The ability to access data and to ability to because that is actually where we can get enormous benefit. I think the other, I would say, caution, I don't want to end with a pessimistic, but just a cautionary tale, is that the climate crisis is in front of us. And I think that their ability for this model, I really hope in 5 years from now, even this model will provide some really targeted recommendation and clinical decision support to respond to the climate crisis that is happening.
Yeah. And I know, and we are now almost officially out of time, but a lot of your work dealing with also the climate implications of the use of AI itself as a technology that requires a fair amount of carbon to actually do what it does, hopefully so effectively for us. I want to, before we just close out, I want to take a moment to thank all 4 of you for just an absolutely inspiring session. I think you've redirected us in multiple ways here to make sure we hit on key pieces of both the potential of this technology, some of the concerns, and many of them quite serious concerns that we might have about how it's applied. Thinking about when we look at the fact that this is a technology that has a potential to increase access and reduce cost for so many things, to make sure that that gets spread broadly across the world. And at the same time, in order to do that, there needs to be a business model to drive someone to drive these innovations under an appropriately, if needed, regulated set of circumstances. So I just appreciate the time that you all have taken to share your insights with us. And again, thank you. So.
Thank you.
Thank you.